sort of comes in. Then from all that, they created this very complicated looking model of direct exchange revision, and we've sort of gone through all this already. So they don't proceed to a second surgery. A successful revision, whether they had a resection, arthroplasty, antibiotics, or mechanical complication, or death. And they did the same for stage revision, and they looked at all the outcomes from this. It's very complicated, but it's actually not as complicated as we could have made it. So in the statistical analysis, they used a special computer program, and they converted all the rates to monthly probabilities, and they discounted a rate set at 3% for a lifetime model. They don't explain what that actually is. And they used quality-adjusted life years on a one-way sensitivity analysis to see how robust their data analysis was, and used 95% confidence intervals, using a difference in proportion approach, which is what they use in meta-analysis. So in terms of their mortality rates, getting to the crux of the matter, any revision total hip replacement from 13,483 patients, which is what they based it on, which was a big retrospective study, has a mortality rate of 2.6%. In the sort of normal population, it goes down to 1.1% if you don't have, obviously, any other medical issues. In the two-stage revision group, there was a mortality rate of 2.5%, but there was a much lower mortality rate at 1 year of only 0.52% in the direct exchange revision group. In terms of the other results that they used, so they found 78%, this is for the stage revision group, so the two-stage group, this is direct exchange group. Success was actually higher in the two-stage group, looking at those outcomes that they defined, 78% compared to 72 roughly. The rate of reinfection was also higher in the direct exchange group, nearly double, 12% compared to around 6.5%. And those treated with a repeat revision rate were also higher in the direct exchange group. So on that basis, you would say that the direct exchange group looks a lot worse. Well, when you actually go to the quality adjusted life years, in the model that they used, they actually found that the direct exchange group, in both the surgeon and the patient, found that if you adjust to the model and decision model they're using, that the direct exchange group had a better quality of life, less mortality, despite the fact that they accepted higher infection rate. So I'll skip through that because it gets too complicated to explain. So the conclusions you've got to, from this paper, the overall balance of risk and benefit favours the direct exchange over the two-stage approach. And the infection rate associated with the direct exchange is roughly twice that found in the two-stage revision. But in this paper they found that you've got to offset that in this analysis that they used by an increased mortality rate after these two-stage procedures compared with that after the direct exchange revision. You've also got to factor in a longer recovery, more recumbency, and the time delay with a two-stage. So they, in their study that they've done and the model that they used, they favoured the direct exchange revision. So, analysing the paper, I think it's a very important area, and because there's such little data available, I think it's actually quite an important paper. And it's quite a useful example of collaboration between health economists and surgeons, because we know that there are major cost implications as well as quality of life implications in this. They had a fairly clear aim of the study and did an extensive literature review. It was retrospective, it was in a single centre with pretty decent numbers. They do acknowledge selection bias in this studies that they looked at, which were generally only level 4 evidence. So really the quality of the study is only based if you're doing a systematic review on the studies that you're looking at and the quality of those. So they did have quite well-defined exclusion criteria and endpoints. They did have quite an explicit decision analysis for both groups that was in that big graph. They did a detailed statistical analysis and did adjust for assumptions and age-related changes. And the sensitivity analysis confirmed the differences in values between the patients and surgeons. And the strength of this, although it's a model and it's not a randomized controlled trial, it actually has set the basis of quite a useful multi-center randomized controlled trial, which I believe they're planning on doing. And they do acknowledge the limitations in the fact that, although there was a lower mortality in the direct exchange group, they don't actually say why. They didn't look at the mortality causation. The weaknesses of the study, they didn't have any conflict of interest, so that's a strength. The study data in the table was from a previous paper, so that I found quite confusing. And obviously the level of evidence is low, mainly level 4 evidence. And the decision analysis model is known to be flawed in high pressure situations. So if you're going to do something acutely, this decision analysis model tends to break down. Potential bias from the low quality evidence from it's based on, like I've said, and they don't really detail the operative procedure and the prosthesis, or whether there's any trends with that. And really, it is quite a complex model structure to get your head around and to present. And it only looks again at chronic infection, doesn't give you any idea what to do with the acute infection group. So how will this influence my practice? Well, like I said, it's got major revision arthroplasty and infections got major implications for the patient, the surgeon, hospitals, and for national healthcare delivery in terms of what you do. It's quite applicable to our unit because we've got quite a lot of infected revisions on the unit. And really, eradication of infection is better with a 2-stage revision. We know that, and that study confirms this. But is that the best endpoint? Further study should help answer those questions. And just finally, it's important to really remember the patient perspective from what we value. They actually would rather live a lot longer, regardless of the quality of their life, whereas we aspire for our patients to have good quality of life, even if it means that they don't live as long. And it's important to really communicate that clearly, I think, before you embark on major revision surgery and infection, and identify realistic expectations and goals. Okay, any questions?
Excellent.